Good morning, good afternoon, and good evening all. Once again, a very warm welcome on behalf of MIT. We are very much looking forward to supporting you today with today's session, taking promising practices for microplanning to the ground. We would like to open with a few housekeeping notes before handing over to Dr. Elizabeth Jere. Please be aware that the session will be recorded. You will be able to view the recordings after the event via the Health Campaign Effectiveness Coalition website. Please familiarise yourself with the programme, speakers, attendees, and networking opportunities available on the virtual platform. All can be accessed from the navigation bar on the left-hand side of the homepage. We would like to encourage interaction. Please use the social media channels to promote and engage a wide audience with this event by tagging @HCE Coalition and using the hashtag collaborative action. During this session, please add your questions to the Zoom Q&A, which can be found at the bottom of Zoom. We will be able to see the questions posted, upvote, and add additional comments. We will aim to answer as many questions as possible during the sessions. Finally, the MIT events team are here to help you with any technical difficulties. Please use the chat facility on Zoom or email the team at events@mit.uk.com. I'm now delighted to hand over to Elizabeth to welcome you to this session. Thank you.
Thank you. Hello, everyone, and welcome. I'm going to share my screen. Thank you for joining us today for Session B, Taking Promising Practices from Microplanning to the Ground. My name is Elizabeth Jere. I work with an organization called AKROS. I'm based in Lusaka, Zambia. So good afternoon, good morning, good evening to those of you that are watching. We're very happy to be part of this, and I think we have some wonderful panelists today to share some exciting, promising practices coming out of microplanning. So before I begin, just briefly, let me just cover who is AKROS. AKROS designs and strengthens information and surveillance systems. We are mostly around the African region, but you can also see a bit of Asia. We strengthen program management and policy decision-making through routine and real-time data collection and use, particularly through geospatial applications. And our roots are in community surveillance and campaign support. AKROS has quite extensive experience in microplanning in these countries. We're supporting countries to improve microplanning through geospatial intelligence and in-field navigation and tracking to improve campaign effectiveness. So we're working in microplanning with neglected tropical diseases in Rwanda and Kenya, and that's a program that I've been supporting. That program is actually funded by the Gates Foundation through EndFund. And we also have extensive experience with malaria, with indoor residual spraying and insecticide treated nets, mainly in Zambia and Senegal. And we're also the primary steward for Reveal. So before we jump into a bit of background on this presentation, I'd just quickly like to share what Reveal is for people who are not aware. Reveal is an open source tool and a global digital good. And just in brief, there's 4 steps to this Reveal tool. The first step is setting up the tool and adding satellite and population data products, such as those from Grid3, Mapbox, Maxar, and others. And then we can also add different risk models and pieces of health data points to help target our population and to be able to visualize on the map the denominator that we're targeting, either at a household level or a community level for the campaign, whether it's malaria, NTDs, immunization, or other campaigns. The second step is to plan and build this plan against the targets that we've put into the tool, but also based on the resources we have available, mainly the human resources, the kind of field teams that we have to deliver services, for example, or drug resources, nets, other supplies, as well as budget resources. Then using the Reveal mobile application, field teams can navigate out to specific target communities and populations and deliver services. And they can also use the mobile application to collect data. And then finally, supervisors and other teams at different levels of the hierarchy of the health system can use various dashboards to monitor and respond to the campaign in real time as it's occurring in the field. And therefore, they can monitor progress and make mid-course campaign corrections to be able to make sure that they achieve high coverage against their actual true denominator, and therefore achieve impactful campaigns. So that was just in brief, but I want to go back now to what we're focusing on now, which is on microplanning. The HCE report in 2020 looked at promising practices in campaigns. And in the area of microplanning, there was group consensus on some major challenges. And in some, these challenges are as follows. First is that, well, it's not a challenge. First is that everyone had consensus that microplanning is important to effective campaign operationalization. However, one of the challenges is that the best practices for microplanning are not being used consistently across programs. And so what we see is in some countries, they've established very good best practices for microplanning for malaria, for example, but when it comes to NTDs, they're not consistently using those same best practices. And that's not just within countries, but also across countries. The group also came to consensus that there are many novel approaches that should be explored for widespread use. But again, those novel approaches are often sitting in a certain report in a certain country and they're not being shared. And so there's also a need to look at those approaches and find ways to share them, but also to do research to determine the applicability of those approaches across various programs. So in sum, the group consensus is that we need to be better about sharing best practices. And so in this presentation, we're going to be looking at some of the promising practices for microplanning that were also identified in that report. So namely, the first area of promising practices is cross-campaign sharing and synergies. Unfortunately, because of often vertical programs or lack of donor alignment, we see these as burdens to effective microplanning. So some programs have incorporated guidelines and best practices for microplanning, but others can continue to be inefficient in terms of their use of their resources. So there's a great opportunity to codify and share best practices across campaigns. The second area of promising practices is in data quality and access. So poor data reliability and consistency often plagues microplanning processes. These inaccuracies can lead to miscalculation of supplies or missing out key populations that should be targeted or improperly calculating statistics. So in the document, participants asked for shared gold standard single source data sets, including for GIS and mapping. So again, we're going to talk a bit about some exciting advances in that area today. The third area of promising practices coming out of the HCE report is community engagement. To ensure relevance and proper engagement with key populations, microplans must be developed in partnership with community health workers and leaders. Key practices identified include bottom-up planning and improved use of communication technology. So again, today we're going to hear some exciting community engagement strategies, particularly from Guyana. And then the final area of promising practices in the report is effective planning, implementation, and management. Both the literature and discussion from the 2020 microplanning meeting highlight the importance of clear microplans that succinctly articulate roles, responsibilities, and expectations from teams. And there were three particular areas of promising practices. First one is under the area of comprehensive microplans and standardization. The second one, supporting supervisory structures and work plan balancing. And the third one was efficiency through mobile technology. So without further ado, I'd like to talk about who our panelists are today. Today's panelists are Estee Garrity from Esri. She's the Chief Medical Officer, and she'll be sharing exciting developments in terms of opening up access to helpful data sets. Our second presenter today is Dr. Reza Niles, the focal point for neglected infectious diseases from the Guyana Ministry of Health. and she'll be sharing Guyana's use of promising practices to strengthen community engagement and campaign management for NTI-MBAs. And our third presenter is Kafula Silumbe, a senior program manager with PATHMA SEPA in Zambia. And he will be discussing the use of bottom-up planning, high-quality data, and mobile technology for campaign management in Zambia. So without further ado, I'm going to go ahead and start with our first panelist. And I would ask that as she is presenting, if people could put, as was noted, your questions in the Q&A. After the presenters, we'll come back to the questions and have time for them to answer your questions. So first, let me introduce Dr. Estee. Dr. Estee Garrity is the Chief Medical Officer at Esri, the developer of the world's most powerful mapping and data analytics platform. She leads strategy and messaging for the health and human services sector and is passionate about transforming health organizations through a geographic approach. Formerly a deputy director with the California Department of Public Health in the US, she led the state's Open Data Initiative. She also served as associate professor at the University of California, Davis, conducting research on geographic approaches to health policy and community development. Dr. Garrity is the author of numerous health and GIS peer-reviewed papers and book chapters. She has lectured extensively around the world on a broad range of health GIS topics, from social determinants of health to climate change and data privacy. She received her medical degree, her master's degree in health informatics, and her master's degree in public health from UC Davis. She is board certified in public health and also a geographic information systems professional. So without further ado, I welcome Dr. Estee to proceed with her presentation. Welcome, Dr. Estee.
Thank you so much. I really appreciate the kind introduction, and I'd like to acknowledge that it really is a pleasure to be a part of this distinguished panel. So I'm going to be talking a bit about data quality and access in microplanning, and I'll also share an example of how we can use existing data in maybe what would be considered new ways to get actionable information. Next. Let's start with a premise that I kind of co-opted from René Descartes. I'm on the map, therefore I am. You know, I got to thinking that in today's world, it is incredibly important to be on the map. If you're not, then you may be invisible from or invisible to governments, to NPOs, or to other health organizations. So then you can't be prioritized or have resources allocated to you. You can't be considered in the access to healthcare and health service calculations, or even be analyzed for other kinds of disparities that could impact your health and overall well-being. So one must be included, and to do that requires good data. Next. So I'm going to be covering some of the best data resources that I know that provide free, quality data relevant for microplanning and GIS ready. And I'm going to briefly review each data hub separately, but I thought you might want to use this chart that I put together for reference a little bit later on. So moving on, let's start with the Living Atlas of the World. Now this data hub has almost 10,000 data sets that come from Esri and thousands of authoritative contributors. The data included here are reviewed, they're curated, and they have associated metadata so that you can really count on the quality. Now on the next slide, you'll see just an example of the results when I searched for Africa and health together. There's data on infant mortality, on malaria prevalence, household size, purchasing power per capita, and much more. Now next is the Africa Geo Portal, which offers specific data for the African continent. Now I've indicated that the countries that are currently providing data for this hub on the slide, and advancing to the next slide, you're going to note that like the Africa Geoportal, there is a specific Caribbean Geoportal with data on land cover and bathymetry, weather patterns, and disaster damage reports. Also, like the Living Atlas of the World, data that is in that African and the Caribbean geoportals, they're curated and they have metadata included. Next slide. Now, the ArcGIS Hub open data resource is a little bit different. This is a huge data repository, and it's contributed to by users from around the world. Now, those may have more or less metadata. They may come from a more or less trusted resource. So you do have to be a bit more careful about your selections because you want to make sure that they're suitable for your microplanning needs. Moving forward, one of the latest innovations has been the Grid3 Data Hub. And Esri's been very happy to collaborate and support this effort to make local data more available. Now you can find it by going to the main page of grid3.org, and then in the upper right, click on data. I circled that there for you. And next, that's going to bring you to this page. Let me recommend that, going back one. Thank you. So I wanted to recommend that the first thing that you do is watch the short video introduction. It's available by clicking on that button in the upper right that I circled. It's going to show you how you can download and visualize and symbolize and use the data in various ways. Now I'm ready for the next slide, where you can quickly determine if the data that you want or need is available. You can just look here. You can click across the various data types, and I'll just let you know up front that there really is pretty good coverage for settlement extents and for population estimates. Some of the other areas are a bit more sparse. In the next slide, I've noted that if you are interested in data for Namibia, Nigeria, or Zambia, they do have more complete data hubs available here. The Grid3 data is also very good about including really nice and complete metadata. Next slide. So in a few minutes, I just covered how you can access nearly 350,000 data sets. Phew, right? Now I want to consider how those data can be used in microplanning campaigns to enhance service delivery. So if we click forward, you're going to see that at Esri, we've actually automated the process for vaccine microplanning to make it easier, and you could apply this to other things as well. So I put a link in the lower left-hand corner so you can get to these tools. And it begins by collecting and mapping existing vaccination locations. Of course, those will be the hospitals, maybe community clinics or pharmacies. Next. Then what you do is you specify the geographic area of interest, and that can be anything from country to region, city, village, or even a custom area. Next. So you have to make some sort of a determination about what, for your area, is an acceptable level of access to vaccination sites. It might be a 30-minute drive time in a city, or a 15-minute walking time, or something else that makes sense for that specific geography and population. With that information, the system is going to calculate the percentage of the population that can adequately reach a current vaccination site. Now, in the following slide, we can begin to work on the gaps, the places where people don't have good access to vaccine. Now, for this, we add in candidates, potential vaccination sites. They're shown on this map in gray. Those could be parking lots for pop-up clinics. They could be schools or any other places where vaccination administration could potentially take place. Next. Now, here we're adding elements of equity that would go beyond the geographic accessibility that we've already accounted for. So we can include any and all factors that are relevant for this specific population. That could be things like population density, language, clean water available for hand hygiene, or a host of other indicators of vulnerability. And all of these attributes would then be used as a weighting factor for the last step, next, which is simply to run the tool. And in the end, the tool selects the fewest candidate locations that would be needed to close the geographic gaps while favoring those places that had the highest vulnerability. Next slide. Now you might think that, okay, well, this is fine tool for the US, but what about other countries that don't have the same kind of data available? Well, I have to say that one of the things I personally love about using geography is it kind of gives us options to create actionable information. So here we're using an example in Uganda where the road network data is quite incomplete. So to supplement the existing data, we've used readily available information like elevation, slope, and land cover to calculate a level of difficulty and therefore the time it would take to traverse various kinds of landscapes, 1 kilometer at a time, and those kilometers are represented by the hexagons that you see. So for example, a flat area with an impervious surface like a road or a sidewalk might only take a person 10 to 12 minutes to walk a kilometer. But then you think of a forested area with a steep slope, that would take considerably longer. The point is, no matter where in the world we're working, we can get to actionable, if even somewhat imperfect information. In my final slide, I'm making my contact information available to you in case you'd like more information or copies of anything that I've shown. And I do look forward to the continued discussion on these topics. And I'll turn it back over to you, Elizabeth.
Sorry about that. Okay. Thank you so much, Estee. That was very interesting. Again, I'm just reminding everyone that if you have questions, you can please drop them in the Q&A and we'll come back to them at the end. But we would like to move on now with Dr. Reza Niles, our next speaker. She is a Guyanese government medical officer and the Ministry of Health focal person for neglected tropical diseases within the Vector Control Services. In coordination with the Ministry of Health team, Dr. Niles coordinated the 2019 and 2021 lymphatic filariasis mass drug administration campaigns, and she now prepares for post-MDA campaign surveillance. Additionally, during these campaigns, she co-authored an article entitled Assessing Factors Influencing Communities' Acceptability of Mass Drug Administration for the Elimination of Lymphatic Filariasis in Guyana. This was published in 2021, and the data provided vital during the social mobilization aspect of the 2021 campaign, when particularly COVID had to be considered. As Dr. Niles continues with this challenging yet rewarding field of public health, she trusts that she will remain grateful for the opportunity of bettering health outcomes and improving the quality of life of those affected by these dreaded diseases. So without further ado, I would like to welcome Dr. Reza Niles to share her promising practices from Guyana. Dr. Niles?
Thank you so much, Elizabeth. And thank you, everyone.
I'm sorry, I'm having trouble hearing Dr. Reza. Is anyone else having trouble with connection?
Yes, we can't hear her, I'm afraid.
As Elizabeth already introduced myself, I'll just say I have my colleagues.
You might find it easier if you turn off your camera and then we'll be able to hear you.
Oh, okay.
Oh, it seems okay now.
Can you hear me now?
We can, thank you.
Okay, great.
Yes.
I think I'll do this then. So you can go to the next slide. Apologies for that. So in Guyana, we were introduced to microplanning through the PAHO, or the Pan American Health Organizations, for best practices that help define our microplanning purposes. The goal was, of course, to have 100% coverage nationwide in all endemic areas. And we've used this for, as I mentioned before, our LF or filaria program. Next slide, please. As you can see, this screen really shows when we introduced microplanning to Guyana, and that was the year of 2017. And quickly, I'll just say, if you notice, the coverage in 2016 at that time in MDA was below the 65 minimum threshold. But after the introduction of microplanning, we all Every year from that, we've maintained an above 65 coverage, and that was what was recommended. And of course, we aim to do better than that, but we did know that the microplanning has paved the way for success. Next slide, please. So microplanning, we normally have 3 levels. The national level is the level that I work at, and the local level is the health center, which really interfaces with the community. Now, normally what we recommend is that they filter their information based on the demographic data from the bottom, from the community, and they filter it up through each and every level. So you'd have a local microplan or the health center microplan, the regional microplan, and a national microplan. And then we, of course, come up with strategies, and it's filtered back down to the end user, really to maximize the coverage and the implementation process. Now, of course, we ideally recommend that this process starts at least, so you can have more time, at least even a year, 9 months before the actual implementation of the activity. Next slide, please. Now, this is the planning strategy that was introduced to us, or basically the steps of microplanning, where we identify boundaries, estimate target, we select tactics, we plan these activities, calculate resources, and we monitor. Now, this is the ideal setting, but of course, challenges remain. Next slide, please. And I'll get into these challenges, and one of them, we put them within the data quality and access. Next slide, please. And what we've realized is, for example, there are many challenges, but I've tried to list a few pertinent ones to this meeting. We had some inconsistent data sources and discrepancies, of course, over denominator, which we know is not isolated to Guyana or even our program. But one of the things we did, as we mentioned with the microplan, we got the information from the health centers who recruited persons to get us this data. And then we tried to cross-check this data based against the census to get a better estimation of the denominator. And of course, this sometimes proved difficult, but it helped us to narrow down at least as close as possible to the real denominator. And that's an uplifted comma. Next slide, please. Also, another constraint is moving from paper-based to digital data. This is a big issue, but one of the things we used Mr. Zuckerberg WhatsApp, and we would share data via WhatsApp on a daily basis. And then we'd have data clerks along with the supervisors, you're seeing in the pictures, inputting this data into Excel file at the regional level and sending it to us at the national level to compile, and then we'd send back reports and vice versa every single day of the campaign. Next slide, please. We also, another constraint was often boundaries between health centers, and most importantly, no man lands, basically areas where health centers would neglect and basically persons would not receive any treatment. So what we did, we would have the maps, we sectoralized them, and we made a plan, and we allocated areas that were not covered to the various health centers and neighbor those areas. Next slide, please. Community engagement, one of the most important parts of the microplan. Next slide, please. One of the constraints that we found here was sensitization, which often needed to parallel the campaign. So one of the things we did, creation of the messaging. So the other before we believe that we would have a poor community engagement. So one of the things we try to do is have sensitization and engagements at the level of the ministries that would filter down to the regional level and then filter to the health center. For example, we would engage the Ministry of Health and we would standardize school-based messaging with the Ministries of Health. We piggyback on their public relations departments for them to share content to increase the amount of persons accessing this data from the different sectors. Next slide, please. Also, we had limited customization plans. At one point, the plans were more of a template than an actual regional. We consider this as region 1, region 2. What we did, We had to make sure we had a sufficient lead time. We found 9 months to 12 months to be adequate, but more use the very data gathered so that we could strategize with the region instead of the national team telling the region. We came up with any strategies together. And of course, engaging the pill distributors, which are the face of the campaign, asking their input. They would be presented with the plan and they were free to say, well, I don't think this might work before because of X, Y. And if it was feasible, we modified or we worked it out together. The next slide, please. Efficient management and planning. That's the goal for everything. Next slide, please. In Guyana, next slide, please. Yes, we had some management tools that we used, quite a few, but some pertinent ones were, one of the things we did was the health centers. We used one of the aspects of the microplan that was paper-based, which is a work plan, or what we would call it a session plan, depending on which region we were working in. And instead of having that paper on a desk, we created that and we blowed it up, I should say, made it a poster to put on the wall so that everyone could see the progress day by day of the campaign and feel encouraged, or they would know that, well, anybody can, supervisor could come in and assess it and work with them to help improve coverage. We also had clear organograms with roles and responsibilities spelled out. We had supervisors checklists for before, during, and after the MDA. We had a transportation schedule that emphasized things like the type of transportation needed for a difficult area and the dates. We also had a Wrapup coverage tool, or what we would call a supervisor's coverage tool, that a supervisor could use during the MDA at the middle and at maybe the second day before the campaign ended. To test the coverage, basically going house to house and requesting few data, and based on that we would know if we needed to go back to that community or if it was good to go ahead. Please, let's go ahead. So of course challenges continued even though we have a lovely plan. Next slide, please. And some of those were getting buy-in for the microplan. One of the things we had to engage, this is a multi-sectoral input that's needed, because I might have the facts, but to translate that to the policymakers can be difficult. So we try to engage our own public relations department, along with the specialists from PAHO and all those persons that were helping us at the time, which are a lot to name, and I have them in my acknowledgement slides. Another thing I'd mention on this slide is that incorporating the social mobilization into the microplan is something I think we were weak on when we began, but strengthened over time. So I would say 2021 was the best year in which we were able to put a little bit more social mobilization planning into the data plan from the level of the health center up. Next slide, please. So what have we learned here in Guyana? The situation in 2017, just to summarize, we lacked strategic planning, we had financial gaps, we had a centralized plan, our tactics was just household, our registry was difficult to tabulate, of project plan and cost estimation, that was one of the things we did. And the microplanning tools helped us to decentralize this information at all levels, up and down. We were able to implement tactics to schools and as well continuing with the household. So we brought into 2 more strategies. We improved our data quality by redesigning the entire registry. That was also, we also tried to make sure everything was consistent throughout the entire microplan with the data registries. And we had post-MDA coverage monitoring, which is the RCM I mentioned earlier, where the supervisors can go into the field. And ideally, what it was used for just as a mop-up strategy, incorporated in the middle of the supervisor had a little bit more evidence with them and to direct the movement of the team at the regional level. We also renewed our communication strategies because we actually hired regional persons for the communication basis in every region. So region 1 had somebody that they could talk and knew the local context, and region 4 had a different person. Or sometimes depending on the region size, they might have the same person. And of course, we reinforce training and supervision. Next slide, please. So as you can see in this last slide, I brought it back here so you can see all the input that came in, and this helped improve the coverage. So Guyana is a little bit more closer to eliminating filaria in Guyana, and that's something we're very proud of. And I know we don't have much time, so I can go to the next slide, and maybe the next presentation we can discuss these things in detail. So in conclusion, I just had 3 points. Planning from the bottom up and top down reduces the gaps, it mitigates conflicts. A robust social mobilization allows for changes and improves community response to the campaign. And clear management of the tools and resources required, they really help the team to implement in line with the plans and the standard operating protocols and to track our coverage. Next slide, please. There was a few questions, research questions, but I know they're mentioned in other probably sessions, but of course the cost effectiveness of the PC microplanning, it is, and I would suggest it's more expensive to invest in a non-effective MD. And this actually came from Dr. Anna Marie Paho, who I'm constantly in contact with, who introduced the microplanning to Guyana, and how we can integrate or reinforce microplanning, and of course what elements promote a good effective microplanning implementation. And I just wanted to put political will was definitely one for us. Next slide, please. This slide is really the acknowledgement slide, so I won't say anything. I just wanted to let you guys know that we are a team of many, and that is why we have been successful thus far. Thank you very much, and you can go to the next slide. Next slide, please.
Okay.
Thank you very much.
Thank you, Dr. Reza. That was very interesting. I think for those of us doing microplanning in other countries, to think about starting 9 months in advance is really excellent in terms of being able to get all those processes together. So again, please drop any questions you have for Dr. Reza into the chat, or into the Q&A box, that is. And let's move on without further ado to Kafula Silumbe. Kafula is actually out in the field, so he has recorded his presentation, but he will be available for your Q&A. So let me introduce him and then start the recording. Kafula is a senior program manager that has been supporting PATH efforts in Zambia for over 10 years. He works closely with the Ministry of Health's National Malaria Elimination Program to provide technical assistance through the insecticide-treated nets, monitoring and evaluation, and social behavior change communication technical working groups. And he also provides oversight for necessary research and field protocols. For the PATH Malaria Control and Elimination Project, which is known as MASEPA for short, he supports community engagement and sensitization needs, as well as government campaign microplanning processes. So he will be talking about the community engagement aspect as well as digital microplanning aspects. So just give me a moment. I'm going to stop sharing and reshare with his recording.
Greetings everyone, my name is Kafula Silumbe, working with PATH MASEPA and AKROS, who are working closely with Ministry of Health with regards to implementing malaria programs on the ground to assist in terms of planning and also ensuring that interventions are adequately covering the populations on the ground. So for this presentation, I will talk about the Zambian microplanning aspects that the ministry works on, and MASEPA and AKROS being partners on the ground. I will basically give you an indication of how we have been working along with other partners on the ground. So just to put things into context, MASEPA is a Bill and Melinda Gates funded program that's been in Zambia since 2005.
And we collaborate with Ministry of Health to test approaches and strengthen the flow of malaria data to leverage some of the new partners to scale what works and what doesn't work. So MASEPA has partnered with AKROS since 2010 to strengthen data collection use in Zambia and Senegal, mainly around LLINs, IRS, and MDA, as well as social behavioral change activities. And with that said, we, in terms of the microplanning support that PATH and AKROS has been supporting the GRZ with, we have assisted the program integrate low-tech maps and technologies into existing microplanning activities, and also ensure that we build core spatial data layers to help inform malaria program planning. And on top of that, we also engage health facility and district staff to use spatial data during resource prioritization. So SBC is one of those aspects that we have been working very closely with the ministry in terms of planning and implementation based on the information that we gather on the ground, so that information gathered is fed into the overall planning process going forward. And of course, all this, we use digital tools, field tools, mainly tablets and phones, to ensure field teams actually deliver to settlements prioritized during microplanning. So programs are uploaded on these tools that will ensure that we're capturing the locations where these maps that have been uploaded on the phones are gathering the information from. So with that said, I'll go into just giving 3 examples that demonstrate these promising practices that I've just highlighted. And the first example I will highlight is the use of the data maps that we have been using all along. So since 2020, the 2020 campaigns, this is an example of a map that we used. And this is a bottom-up planning sessions for IRS and ITNs, which is basically allowing the districts and facility staff to feed into the planning process. So they basically look at these maps, and then they are able to prioritize where they essentially know where they need to send their resources that are very limited. And the maps include data on targeting and campaigning coverage from previous years. So this was 2020, 2019 campaign year. And the following year, we were able to generate new maps based on the maps that I just highlighted earlier. So these maps are for the 2020-2021 malaria season. And basically this map with input from the districts, as I mentioned, the bottom-up approach, was able to highlight the areas that will need to be targeted for IRS, and then differentiate those that are targeted for ITNs from the previous year. So based on population estimates, you'll be able to prioritize, especially in a resource constrained environment like Zambia. We really need to ensure that the interventions are going to all the populations across the target areas, but segmented in terms of where IRS campaigns need to take place and where ITN are also going to take place. So this is a map that was generated from the previous maps that were developed going forward. And also example number 2, mobile technology that we use from the maps, generated from the maps that I highlighted earlier. The tool that we use is Reveal. So Reveal deploys, we deploy teams using the Reveal tool, and they monitor campaign progress through near real-time data dashboards to hold teams to microplan decisions. So the Reveal user interface enhances campaign effectiveness through assignment of field teams to targeted settlements, and they navigate to those particular areas to ensure that there's adequate structure coverage. And then in-field accountability is one of the strong aspects of Reveal, because everybody is accountable for that area that's been assigned, and Reveal is a good tool to track whether individuals are tracking those particular households or structures that they're supposed to target. And this is done within 25-meter radius of that index household, if I can call it that, for that accountability to take place. And then also there's offline coverage with review. So even if the phones or tablets are not offline, you can still track the progress as this, the data can be seen offline and you can verify the information that is coming in. And lastly, subnational and national level remote tracking of coverage and field staff performance through dashboards is one key element of review, because you want to know whether your field teams are performing the tasks that have been assigned. So once they start using the review tool, you'll be able to track the progress of the teams on the ground. And just to highlight what review looks like, at the moment, we have 2 versions of review on the ground. So we have what is referred to as light touch review, which is to ensure teams visit areas prioritized during planning. So this particular version of review requires less gadgets on the ground, meaning that you have a less footprint in terms of tools going on the ground. But nevertheless, in terms of coverage, in terms of monitoring what is going on the ground, it's still as effective to capture all the essential elements that need to be captured as the teams are going around. And then the second version is the full review. The full review requires as many tablets on the ground, many tools on the ground, to ensure that all the structures, all structure level index houses are covered, to ensure high coverage within operational areas in priority districts. And the last example I will give, I mentioned that I'll cover 3 examples. The last example is basically we have worked closely with AKROS in terms of data collection of SBC penetration. With regards to penetration, we're trying to understand what is on the ground as individuals are collecting the data, whether the messages that have been generated are actually reaching the ground. So the data we collect can help understand the association of malaria messages with intervention uptake. And this should be directed to the people on the ground, which is the health facility staff and community health workers, and radio, to focus their SBC resources to those areas where we know from the review tool where the data has been collected, where there are gaps on the ground. So that is one of the third example that I wanted to highlight. So some of the key closing takeaways from this whole partnership and integration on the ground with the tools and the partners and the districts themselves is that the right spatial data helps decision makers to make more accurate decisions to determine how many resources, how much needs to go to a particular area or district. And also, secondly, putting data in the hands of frontline health workers who are closest to the people, closest to the action, actually, allows for more efficient and effective campaign decision making. And then lastly, mobile tools, and in this case, we've been using tablets and phones. They have been helpful in ensuring microplans are effectively carried out and can help maximize impact for money spent. So in a nutshell, this was a presentation that basically shows the partnership between PATH, AKROS, and Ministry of Health to ensure that we are covering all the areas on the ground in terms of microplanning towards ensuring effective coverage of interventions on the ground. I thank you for your attention and have a good day.
Okay, unfortunately, I believe we only have 1 minute left, which means I don't know if there is enough time to take questions. So I think at this time, I'd like to thank our speakers. I think we have a lot of questions that they can be answering if people want to just drop any follow-up contact information. And also in a chat, notice that if you want to discuss these ideas more, you can join session E in the next round of breakout sessions. And there'll be ongoing opportunities to connect via the HCE Coalition. So thank you very much to Dr. Estee Garrity from ESRI. Thank you, Dr. Reza Niles from the Guyana Ministry of Health. And thank you, Kafula Silumbe from PATH Zambia for this excellent, promising practices on microplanning. Thank you very much on behalf of AKROS for giving us the opportunity to facilitate this session.
Thank you very much, Elizabeth. And on behalf of the MYT events team, it has been our pleasure to support you today. Please do join at our next session, Session D, Experiencing in Campaign Integration. Session E, geospatial data solutions for improving health campaign efficiency and effectiveness. Session F, campaign integration with PHC systems. From the homepage, click on the platform on the program tab to choose your session and join the meeting. Our next session will begin at 10 o'clock EDT after a short 10-minute break. Thank you very much.